Decision making in implantology is the title of our lecture today. Once upon a time, implantology was a new idea. And like every new idea came through three stages. First stage, not being taken seriously. The second stage, being attacked. And the third stage, being self-understanding. I had the opportunity to follow the implantology maybe at the end of the first stage and starting with the second stage. So this is not indication of my age. But anyway, I have some experience from that time, and we struggled really very hardly to bring implantology to this position where we are, being self-understanding. But maybe we can add a fourth stage today, which is in some areas, some places, a kind of exaggerating and don't be aware, not awareing of some risks which are very important to be taken into consideration when we are talking about implant. So it is not here, I'm not here today also to say that implants are relative good or not good. In contrary, I am the one who is really always struggling for position in the implantology, in the dental fields. For the sake of implant reputation, we need to avoid risks and choose predictable procedures. And we should always remember that implants are really a part of oral rehabilitation, and that's what the dean in his speech maybe mentioned indirectly, and not a goal of the treatment all the time. There are a very long list of aspects in this decision making. It's almost like the same decision making in oral rehabilitation for whole dentistry. But it's, of course, it is not for half-hour lecture, wouldn't be enough to discuss all these aspects, but I choose the most important things. When we look at the patient, we are not planning to put implant just for the implant, but we are making implant for prosthetic rehabilitation. So we should also think prosthetic work with or without implant. It's not always the implant work is the best one. We could think by this decision, is it removable or fixed denture? The relationship between implants and periodontally compromised oral cavity is a very important aspect. That's why we are concentrating today of hygiene and the post-operative care, and that's why you will hear in these days many lectures about photodynamic therapy as a prophylactic or as a treatment aspect. And then we have to also discuss the implant augmentation, since we know, according to different reports, that it is sometimes difficult to get excellent results always with the augmentation, and this augmentation should be really done in a perfect way. So that's why decision making it is difficult also to separate all these aspects from each other. That's why it's better to bring you some clinical situation and we discuss them and see what is predictable and what is not predictable. If you are in your dental clinic, dental office, and you have this case, you will find a very atrophic area in the lower mandible. I mean, there is only cortical bone from the lingual, and you need to, give the patient a good solution. The implant solution means augmentation in this critical area and waiting a very long time, but it's a good option. And the other option is, of course, to make a bridge to crowns on these, and we have a cantilever there, a pontic. Even though for this situation, I started with augmentation, because even if the patient later on decided to take the classical solution with bridge, it needs to make some contour for the pontic. So we have now enough time, or we can discuss the situation with the patient. If you want implant, we have to wait a very long time. If you want to have a bridge, we can go for like 4 or 5 weeks later, we start with the bridge. Also, we have, if you want to make implant to be on the safe side, the question is where to put the implant. If I have such a defect here, this tooth should be extracted, and we need to make like postponed immediate implantation. So we have to choose the wall where we have the own bone. Augmentation can be done in the rest of the alveoli. So it is better to put the implant in this area, not to put it in this very big defect here. We have a very long wall, distal wall, and we can cover the augmentation in the rest of it. So this is 6 years after putting a Sky implant, and we have we find nicely the augmented material in this situation after 6 years. A stable result. Again, where to put the implants? I have here, So I have here also a very big defect. The whole cortical bone is lost, and we have here intact bone. With the bridge, it is not acceptable to, according to this level in dentistry today, we need to cut or to prepare 2 teeth here, the canine and the premolar, because of the long space here and because it is in the lower jaw. So to put implants in this case and to save time, I'm not going to put the implant here and here. Here is more risky, so I go for putting the implant like this, 2 implants in the safe area, but at the same time augment the defect in the same session. And I have the situation like this. Then it is easy to make a nice bridge with small cantilever, which is very acceptable. Very classical situation. We have 2 situations here, We have 2 situations. Here's, as you know, a definite or absolute indication for implant because we have intact or no caries on the neighboring teeth, and we have a very nice contour here. Here we have, a situation where the neighboring teeth are crowned, and almost maybe everybody will agree with me that these crowns needs to be changed to be more nicer from aesthetic point of view. And we have also a defect somewhere here, like a dehiscence. So the choice here is really very clear. The choice here, it's up to you. It's happened that this patient is a referred patient from a dentist where they asked me to put an implant here. So if it was my patient, and I know that this patient may be impatient to wait for all situation and with not predictable maybe results, so I would prefer the bridge in this area than to make implant. For this situation, the first one on the right side, it is ideal situation as I mentioned. There is intact bone here, and it is a very ideal situation to put the so-called delayed immediate implantation. And this device from Bredent, it's a very fantastic device to put at the same time a provisional crown on this implant without loading, of course. So this is an ideal situation, so you can do this. But this is not like thinking all the time, immediate implantation, like we hear. You should really clear the situation before you choose for this solution. If we go to the other one, where I told you that the dentist want me to put an implant, we have also here a very predictable situation that the bone in the proximal area is intact. So this is a very good or positive situation. Now, but we still have a dehiscences here. In this case, where I have dehiscences connected to the mouth, I prefer always to cover all material I put in it. So in this case, we get the osseram, as you see here from Bredent, a nice, very good, nice bone substitute material, and use the angiopore, the membrane. And very important here, to cover the whole, sorry, to cover the whole, sorry. So, and to cover the whole defect, and that's why the incision you see, I did 2 oblique incisions to move the flap and cover 100% because of the dehiscence. The situation is a little bit different here. When you see there is a fenestration, as you expect in this situation, and there's a secondary caries around this post. So when we open the area, we expect a fenestration, but we still have a good soft tissue. In this case, I use the bone serum around the defect here. Again, we have a very good bone supporting here. But now I used a non-resorbable membrane in this case because I don't want to move the flap. I want only to cover without moving the flap. This non-resorbable membrane, it is PTEF. It is the only membrane we can leave it open in the mouth. So, and you can see that I use only 1 oblique incision, leaving this area here intact, and expect to get the best aesthetic result from this situation. Now, moving to another aspect, we have here all the bridge, and you can see here that these 2 teeth have to be removed. The bridge was cut in this area. 2 blue sky implant after sinus lift were inserted. And this is a very stable result after 7 years. But the patient came later with a problem, not with the implant. The implant bridge was there's perfect healing here. Look at the soft tissue, and the whole situation was perfect. But we have a problem with this bridge. Try to maintain this situation, but it failed. The ceramic was broken many times, and we have here a very long distance between this abutment and here. So we discussed the situation with the patient. Either we make another fixed bridge. This is the question here. Is it a fixed denture again? And leaving this implant in place, making a new bridge here, or move to a removable denture. We are taking also the age of the patient into consideration and the possibility of the denture to be repaired with the time. So this is a very important aspect. Discussing this situation with the patient, we decide to make a conical crowns or telescopic crowns on the implant and on the rest of the teeth. So this solution is capable to be changed in the future if one of the implant or one of these teeth has to be removed. We still have the option to repair this denture without changing the whole situation. So we have a very aesthetic, we are very flexible here with this removable denture. We have aesthetic results, and we can, as I said, maintain the whole this denture for a whole long time, maybe lifelong. The question of connecting teeth with natural teeth with implant, this is an ideal situation for connection. This is a space which is longer than to have two implants. I mean, it is long enough for one implant, and it is narrow for two implants. In this case, when we find that there is also caries on the neighboring tooth, this is ideal situation to connect. This is a vital tooth, multi-rooted, and when I connect normal tooth with implant, I use always the extracoronal attachment, but it is a fixed extracoronal attachment. The crown on the implant will be fixed with temporary cement. The crown on the tooth will be fixed with definite cement, with like Harvard. And any time where I need to go to open the area and to find to see the implant, I can remove the only part, this part, separated from the other part. So for me, it is the safe way to connect, if I connect. But please don't connect implant with endodontically treated teeth with a post. I really see over the years a lot of problems, not in the implant, but in the teeth themselves. You see, maybe you can see this fracture of the, actually after a short time of this nice all oral rehabilitation. All of them are blue sky implants. Here are some sinus lift implant, and we did a very good result, but this one is very, disappointing. If this situation, we have this situation where this tooth has to be removed, and we have a very long span between the lateral incisor here and the second molar, and we have these teeth are vital, but they are not really strong enough, in my opinion, to rely on them. You can, of course, put an implant here and connect it with the molar, but to be on the safe side, I decided not to do so. I decided to make the sinus lift, and this is bone serum, this is the angiopore, and we get this situation where we find two implants, we can make a bridge on them, we can crown this tooth, and we can crown this tooth, and we are on the safe side. Now, if you have this patient in your office tomorrow, this is a situation where we did a successful periodontal treatment, and this tooth, from the beginning, was a hopeless tooth. It has to be removed. Do you choose an implant to put in this area, or are you going to choose bridge? This is an important decision here, because we have some aesthetic problem here, and we need to improve the aesthetic. But we have here a severe aesthetic problem when we remove this tooth, and we need, you can put implant, but of course you will need a very, very long time of augmentation, bone substitute material, soft tissue augmentation, and the result probably not predictable. We don't really tell from the beginning that you will achieve the goal you want. So in this case, I myself would not go for implant. This is a case that I'm going to solve in the near future. That leads to the question. It doesn't mean that I don't use implant in the periodontally compromised mouth. Of course we can do, but we need to make initial periodontal treatment before we start with anything. And here again, a similar situation, this tooth has to be removed. And these are compromised teeth. I'm not going to connect implant with periodontally compromised teeth. I would go for the more stable plan, which is, first of all, remove the tooth, make some mucogingival surgery, give the patient a long-term provisional, and I mean with long-term provisional with metal, because this long-term provisional should stay in mouth, in the aesthetic area. The patient otherwise will come every second day and say, oh, this is movable. So a good provisional is mandatory. And now I have the time to go to the lateral area to make sinus lift and put implants, and the whole time the patient has its bridge. So this is the oral rehabilitation of the patient. These teeth became very solid and very good to have a good bridge in the area. And we have 3 implants every side after sinus lift. This is our also blue sky implant. And we have the situation, 3 separate bridges, 1 in the front on the normal teeth and 2 on implant. We are on the safe side. And this is the patient after the oral rehabilitation of the upper jaw. And this is something done 10 years ago and stable. Stable also, of course, with good oral hygiene, stable with post-implant treatment, with good professional cleaning, and using, once needed, photodynamic therapy. What I'm not going to talk about it. There's enough lecture will discuss this situation. I hope with this short talk about decision making in implant that I give you some idea that not always implant is the solution of everything, and we have to see the implant as a part of the oral rehabilitation and not a goal in itself. Thank you for your attention.